folks will find their way to us. I see we do have some people on the call, so we want to go ahead and get started. Welcome everyone to the October session of Pain Research Working Group. For those of you who can believe it's October already. So today we are very pleased to have Dr. Jung with us today. He's going to talk about trajectories and individual differences in pain, emotional distress, and prescription opioid misuse among individuals with chronic pain during the COVID-19 pandemic, a one-year longitudinal study. So Dr. Moon is an assistant professor at Edson College of Nursing and Health Innovations at Arizona State University. He directs the Biobehavioral Pain Addiction, Sleep, and Momentary Experience, or BiPASS-Me, Research Laboratory. Utilizing smartphones, wearable devices, and quantitative sensory testing, his lab aims to understand the biopsychosocial individual differences in pain coping and adjustment, the role of sleep and circadian rhythm in cannabis use in pain and opioid use, as well as treatment and prevention of chronic pain and opioid disorder. Thank you very much for being with us today. I'm very interested in hearing about this study. We'll hand it over to you. I encourage folks to put their questions in the chat, and then we can attend to them at the end of the presentation. Thank you.
Thank you so much for introduction, Dr. Hippie. And thank you all for joining in today. My connection with Connecticut VA actually dates back. I just talked with Dr. Hippie about this, but it dates back to 2017. I was clinical psychology interns at Yale, and while I was doing internship, I got connected with Dr. Robert Kearns, and through him, I was able to get connected with a number of researchers at the Prime Center at the Connecticut VA. I can't believe that already 4 years have passed, and it's really wonderful back here, at least virtually, and it's my great honor to have the opportunity to share my research work with you. Today, I'd like to really focus my presentation about sharing some really fresh new findings from our longitudinal study that examined the impact of COVID-19 pandemic on chronic pain. So as you are all aware, experience of pain is complex as it is influenced by a host of biopsychosocial factors. And pain is not only shaped by biophysiological stressors, but also various types of psychosocial stressors. And the reason that I say this is because COVID-19 pandemic is indeed a unique stressor. This pandemic so far resulted in more than 4.5 million deaths around the world. And this number is crazy because it is more than the total casualties in World War I. And this is just like a little more than a year and a half since the pandemic started. And it is ongoing. The pandemic also resulted in really unprecedented social distancing, stay-at-home orders, and also mandated mask policy, which is all still largely impacting our day-to-day lives, not just in the United States, but across the world. And needless to say, the pandemic has also been causing countless number of people's job loss, financial insecurity, and also substantial increase in childcare burden, which I'm also experiencing because I have a 2.5-year-old daughter, and she's actually staying home because we are concerned about the Delta variants. And yeah, I don't know when she'll be going to daycare. Today it was a little bit special that I came to my office a little bit early to do this presentation, but yeah, it's a real burden for a lot of people. So it does seem that the pandemic can be quite important stressor. And it's wondering like what the actual literature say about this. Well, first of all, there are a number of studies that actually that conducted just after pandemic started, and they have really mixed findings in terms of like how pandemic has been impacting individuals with chronic pain. Some studies suggest that there has been like substantial increase in pain severity and interference, whereas some studies, including actually our baseline study, it suggested like not a lot of like changes in pain in the early phase of the pandemic. So the pain focused kind of outcomes are like largely mixed, but in terms of the emotional distress, like depression or anxiety, there is some consistency that at least in the beginning of the pandemic, most of the studies have been reporting that people exhibiting like worsened depressive and anxiety symptoms when compared to before the pandemic started. But really important thing to note here is that all of the studies that I'm aware of is actually based on cross-sectional study design. So we don't really know the longitudinal impact of pandemic on various pain-related outcomes like over time. And we only know most of the studies was also done in the beginning of the pandemic, so we don't really know what's happening now, for instance. So to address this, we conducted a longitudinal study. But before we jump into our like fresh new findings, I'd like to briefly review what we found in our first wave of the data, which was published early this year, and it was of April 2020. So we were in, and I think the findings are actually quite relevant to our longitudinal findings. So these results are, as I said, based on our first wave data, and we had decent number of participants whom we collected from MTurk. So there were about like 1,500 people. And most of us were in the middle of the lockdown. And when I first looked at this result, I was a little bit surprised that while in terms of like mood and there has been some kind of deterioration that people reported like early phase of the pandemic. But in terms of pain, like pain severity or pain interference, which are poor pain outcomes, majority of people reported that there has been no change, although there are some like some worsening symptoms reported, but the majority of people really reported that there has been no change. And this was also the case for the social support, perceived social support. How about the impact of pandemic on chronic pain treatment? And this is again from the same paper that we published. And in the case of mental health treatment for chronic pain, it was quite evident, although there are a lot of people reported that their sessions has been canceled without no future like guarantee of their sessions were postponed. But it was quite clear that the treatment providers quickly transitioned into telehealth or telemedicine session. And I think this is now really widely used in many different settings. But that was not the case for some other chronic pain treatments, such as physical therapy or some other complementary medical treatments, such as massage, acupuncture, or chiropractic care. These treatment options, like it just not easily transferable transition to telemedicine. So a lot of sessions were canceled with no future sessions scheduled. And yeah, it had a huge impact on options. And again, this is really the beginning of the pandemic, and I'm unfortunately no longer working in a clinical setting, so I don't really know what's going on these days. But at least from my colleagues who are working in the rehab center, they were saying that the situation is has been becoming a little better. But I think it would be really nice if we have some more empirical data on this, especially in terms of the impact of pandemic and the treatment. I'm still aware that some surgery options are sometimes canceled when there are cases spike, but it's just difficult to know how it's I'm pretty sure there's a huge difference among states as well. So if anyone knows any data regarding this, please let me know. I'll be really interested in learning more. The impact of pandemic on self-management of chronic pain was actually quite interesting. Not only that, about half of the people who said that they use self-management reported that there has been no impact. But there were also a little bit slightly greater proportion of individuals who reported that they practiced more than usual during the pandemic. And I'm a clinical psychologist by training, and looking at this, I was actually very impressed because the pandemic has been really difficult for a lot of us, and still during this difficult time, people actually put a lot of effort in practicing more. And that was quite impressive. And I was wondering whether this is actually directly related with these outcomes that we saw before, that a lot of people did notice a lot of change in terms of their pain-related outcomes. So based on these findings, we collected two additional waves of the data at 3 months and 12 months follow-ups. And we were really interested in addressing 3 specific research questions using this longitudinal data. The number one question was, of course, looking at the impact of COVID-19 pandemic on various domains of pain-related outcomes, including pain severity, interference, depressive and anxiety symptoms, as well as opioid misuse behavior among those who prescribe opioids. The question they were interested in asking was that really trying to ask this question whether there is specific socio-demographic subgroups that are at risk for experiencing difficulty in coping pain during this pandemic. And we already know from previous literature there are some really pain disparities in certain underrepresented racial ethnic groups and women and those who are under-resourced. So I was wondering whether those groups might get more impact on various outcomes over time during the pandemic. And the last question was relating to kind of identifying whether there are some modifiable individual difference factors that can moderate the trajectories of pain-related outcomes during the pandemic. And here, we were specifically interested in exploring the moderating role of pain catastrophizing, pain acceptance, and sleep disturbance, which are all targetable through evidence-based psychological interventions, such as cognitive behavioral therapy for pain and insomnia, and also acceptance and commitment therapy. As I briefly mentioned earlier, this study was based on a fairly large number of people recruited from Amazon Mechanical Turk, MTurk. It's an online crowdsourcing platform that you can basically administer surveys and collect data in a fairly short period of time across the United States. And we used a third party called Cloud Research, and they actually collected the data for us. And they have their own they have their own kind of pool of Amazon MTurk workers whom they've been screening for their reliability and validity of responses. So we trusted them, and hopefully that is the case, and a lot of people are using these days. So anyway, we paid literally more premium to have more reliable and valid data, because there's always concern on that sample. And also another notable thing is that we try to oversample women and African American race and Hispanic ethnicity to really achieve a sample that is similar to the like chronic pain population. Yeah, it's of course it was not like exactly same, but that's like we tried our best to try to match these proportions. And then we collected data 3 times, and I actually wanted to show you this. I graphed this through R, and the x-axis is the date, and y-axis is the COVID-19, like the new cases that I actually downloaded the data from CDC, and I just plotted this out. And I was wondering exactly when we actually collected our data. And I was, of course, we were not able to predict the progression of the pandemic, but looking at this figure, I was thinking, man, it must have been nice if we actually had some additional assessment that was conducted in the winter time, where there was like the new cases was at its peak, and we didn't really intend this, but turned out that all like time 1, 2, 3 assessments, there are fairly like relatively lower cases during this period of time. So yeah, in the future, maybe, I don't know, the cases are still increasing, and we're planning to collect another wave of the data. So maybe we'll just have to look at the. In terms of the retention rate, it was fairly decent. It was about like 60%, and it's not terrible, but it's not great either. But in terms of like MTurk sample, this actually retention rate is pretty good compared to other MTurk studies. We had 5 main outcomes that we were interested in. Pain severity, interference, which was measured by brief pain inventory, and anxiety and depressive symptoms from PROMIS measures. And also among those who prescribed opioid medication, they also filled out some pain medication misuse. And in terms of moderators, we included sociodemographic variables, pain catastrophizing scale, pain acceptance, and we're indexed to measure sleep disturbance. And by the way, for those who may not be familiar with the concept of pain catastrophizing and pain acceptance, pain catastrophizing is really a robust measure that predicts pain-related outcomes. It's a kind of dysfunctional cognitive and affective reaction to pain, and pain acceptance, on the other hand, is like more like individuals' willingness to stay with pain, and also engage in meaningful activities and their values. So both of them are actually like well studied in the literature, and they are robust predictors of pain related, as well as opioid related. In terms of analysis, as we were really interested in investigating the trajectories, we used growth model. So given that we had more than 2 data time points, we had 3. So we also tested the quadratic like time trends. And as there were like many different outcomes, we were concerned about the family-wise error. So we reduced the alpha level from 0.05 to 0.01. So this is a brief summary of the demographics, and we weren't able to match with the education and like SES measures. We were at least try to follow the chronic pain population in the U.S. in terms of the gender, race, and ethnicity. And as you can see, the COVID-19 pandemic at the baseline had really substantial influence on individuals' employment status. About like half of the sample reported that they got furloughed or they're working because of the pandemic. And also in terms of some other notable clinical characteristics in the sample, a lot of people were actually really dealing with chronic pain for a long time, on average like 11 years. And about 1/3 of people reported that. So these are the graphical representation of trajectories of 5 different outcomes that I mentioned before, and this is across 1 year. As you can see, for the past 1 year during the pandemic, contrary to our expectation, or like our general kind of like logical guessing, like actually none of the pain-related outcome trajectories show like really a spike or exacerbation of those symptoms over time. And although we were quite surprised with this like counterintuitive results, we were also kind of relieved that at least participants in our study were not actually were actually doing fairly well in terms of many different domains of pain-related outcomes. And and again, as Dr. Moore said, that it's fairly like consistent across different outcomes. So we were quite surprised and also relieved. But yeah, like overall, like for instance, anxiety and opioid misbehavior trajectories, they were more like kind of linearly like decreasing trend. We couldn't find really quadratic trend. But for pain severity, interference, and depressive symptoms, there's some decrease in the first like 3 months, and then there's some slight increase in those symptoms 12 months like later. But still, it was not at the baseline. Maybe it's not correct to say baseline, but not at the level of when they first got assessed on like April, May. So yeah, we were quite relieved that people, at least in our sample, were doing okay, and hopefully this is actually true. And as a next step, we tested whether the outcome trajectories are moderated by demographic variables, but it turned out that none of them were moderating the time trajectory. So I just took the findings out, and here I'm really focusing on the main effects. First of all, and because there are so many outcomes, I just visually highlighted those findings that are significant. So individuals with older age, they are actually having lower depressive symptoms, anxiety symptoms, and also lower levels of opioid misuse behaviors compared to younger individuals. And in terms of women, they were reporting more pain severity, interference, and anxiety symptoms overall during the pandemic compared to men. But in terms of opioid misuse behaviors, they were actually reporting less opioid misuse compared to men. I think these are all actually consistent with previous literature prior to pandemic. And yeah, interestingly, we didn't really find some racial differences in terms of all different outcomes, but in terms of the ethnic difference, we found that those individuals who were identified as Hispanic reported greater pain interference and greater opioid misuse behaviors compared to non-Hispanic individuals. And SES measures were also associated with different outcomes, like income, education, for instance. The lower income and lower education, as I indicated, I coded binarily, 0 and 1. 1 indicates lower income or lower education. They were associated with greater level of pain severity. In terms of income, the lower income was also associated with greater interference and pain interference, and which are again, it's fairly consistent with previous epidemiological kind of studies. In terms of the moderating effects of pain catastrophizing, pain acceptance, and sleep disturbance, we found that except pain acceptance, pain catastrophizing and sleep disturbance didn't really moderate the trajectories. And pain acceptance was significantly moderated in terms of pain severity and depressive symptoms as outcomes. And we'll definitely get back to this moderation results more in detail in a minute. But I just wanted to kind of on also the main effects that we found here in terms of pain catastrophizing and sleep disturbance. Those individuals report greater level of pain catastrophizing and sleep disturbance, reported like the overall greater level of like pain, emotional distress, and like in terms of catastrophizing, they also reported greater level of opioid misuse behaviors. And yeah, these are like really consistent finding with the literature as well, that these factors are often really robustly associated with all those like core outcomes. And as I promised, I'm getting back to the moderation results of pain acceptance. I'm more like visual person, so I try to visualize this by kind of separating out the pain acceptance to two different groups using median split. And the orange line indicates those people who have overall low pain acceptance, and the blue line indicates those people who have high pain acceptance level. And as you can see, those people who report like overall low pain acceptance, their pain severity and depressive symptoms are actually quite like moderate and pretty stable. Or even for depressive symptoms, I can see that it's like slightly increasing over time, which I thought that is really interesting. But in terms of those people who have overall high level of pain acceptance, it's not only interesting that they overall started with like lower level of pain severity and depressive symptoms. Like really in terms of depressive symptoms, it's a PROMIS T-score. So the 50 actually indicates the mean level of population, and the 10 unit change is actually indicating the 1 standard deviation. So they were actually fairly at the like average level when they were starting. But really interesting thing was that over time, they were actually improving in these outcomes, which I thought that it's interesting. And this reminded me of the literature on resilience, not really relating to pain, but like a lot of times adverse events or adverse like life experiences. There are some people who are like resilient, and they actually, although there's some spike in their like emotional distress or deterioration of quality of life, but they actually can recover and actually grow like even more over time. So perhaps this is what we are observing here. So clearly, the pain acceptance had some buffering effects and also helped people with chronic pain really thrive and function better over time during the pandemic. We went over a lot of findings from this fairly complex data set. So let me briefly summarize the key findings here. First of all, various domains of pain-related outcomes, as you saw in the graph, they didn't really significantly deteriorated over time in the duration of 1 year since the pandemic started. And none of the socio-demographic factors in pain catastrophizing and sleep disturbance moderated the overall outcomes. But it is really noteworthy that some socio-demographic factors are significant main effects. So being young age, female, Hispanic ethnicity, and low SAS are all associated with overall poor pain-related outcomes. And pain catastrophizing and sleep disturbance were also had significant main effects on many different pain-related outcomes. And I actually forgot to mention this in terms of the effect size. Actually, the addition of pain catastrophizing and sleep disturbance and pain acceptance in the model really explained a lot of variance of all those outcomes. It was ranging about 20 R square of 0.2 to 0.5. So like 20 to 50% of variance was explained by those demographic factors and also individual difference, psychological individual difference factors. And lastly, individuals with greater pain acceptance reported greater improvement of pain severity. But what are the key take-home messages here? Well, at least our sample, like we can definitely cannot generalize these findings to all other pain in the United States, but at least in our sample, we didn't really find strong evidence that the chronic COVID-19 pandemic is significantly deteriorating pain, emotional distress, and opioid misuse behavior. And I think the impact here is overall quite smaller than we expected. And it was really interesting to go back to some more broad literature that examine the impact of catastrophic events and disasters on pain. So for instance, I found a really interesting study that was published a while ago when the 9/11 terrorist attacks happened. So the study actually looked at those residents in the New York City and New Jersey with fibromyalgia-like symptoms, and they actually reported no really significant changes in their pain symptoms before and after the terrorist attack happened. And similarly, my colleagues who's Jewish, and she was actually researching in Israel a while ago. Cheryl Lerman and her colleagues found that patients with chronic pain who were 3 weeks of missile attacks in the southern region of Israel, they did not show any like significant changes in a more like affective domain of pain, depressive symptoms, and anxiety symptoms. So it seems like that we definitely cannot make automatic assumption that like because of those like really unique stressor things going on in our life doesn't necessarily mean that everyone will actually experience like exacerbation of their like chronic pain related outcomes. I think it might be really relating to how personal these kind of events are to the. We didn't have enough data to look at this, but I'm curious to like explore a little bit more. For instance, if those participants who either they had COVID-19 and struggled with the infection or witnessed their family members or close and friends or family members really struggling from COVID-19 might have had greater impact on their pain or all different kind of domain functioning over time. But there were two low cases, and we weren't able to really kind of better, like more detailed information on this. So maybe in the future study, we can definitely explore this a little. Yeah, another I think important message here is that the pain disparity is real and it is constantly reported in all different kinds of studies. And we really need to address, I think, this. It is definitely a challenging topic because there's no single intervention that can change this. So we need really more like structural transformation and system change. But definitely those individuals who are advantaged, and women are definitely struggling more in terms of adjusting to their pain or coping with their pain. Lastly, our findings like is kind of signaling. I'd like to see a little more studies on this, but kind of signaling that among kind of different target variables, it might be kind of maybe most important to focus on pain acceptance. And we already know that there's a evidence-based intervention that can target that. And this might really help individuals with chronic pain to be resilient during the pandemic. Of course, our study was not without limitation, as we were not able to predict the pandemic. So we actually couldn't collect the data prior to the pandemic. So we don't really know what their true baseline level of those all different outcomes were. We were also, so this was part of, this was not the main study. We actually, this is actually more like kind of secondary projects that I was really interested in exploring. So it was a little bit limited in terms of like adding some additional measures, but yeah, I wish we measure a little more about the social isolation because I am well aware that some people are still very like socially isolated, but we didn't really have this measure to really identify those individuals. Perhaps these individuals might have not been doing very well during the pandemic. And another thing, as I mentioned before, is that we only had like only 3 times that we measured during the pandemic, and there is certainly that the time that we missed in the like at the peak of the pandemic. And also, we as you saw from the figure, for some outcomes, we're kind of seeing some slight increase in these outcomes in terms of their severity. And I think it might worth to kind of explore a little more in like longer follow-ups. So planning on trying to collect the 2-year follow-up assessment. And hopefully this can shed further light. Lastly, I would like to acknowledge my collaborators at Hopkins who have been critical in conducting this study. And thank you everyone for your time, and I really appreciate attention, and I welcome any questions.
Great, thank you so much, Moon. We really appreciate that, and I will say I really liked your slide where you superimposed the assessment periods over, I think it was COVID infection rates. I thought that was really a nice visual there. So I see that there are a couple questions already in the chat, and I'm going to go ahead and ask those, and I'm going to encourage other people to put questions in the chat too. And then after I ask the question poser should feel free to ask any follow-ups if anything wasn't clear. But so I'm going to start here at the bottom. So David Reed was asking about the mTurk sample. So what methods were used to ensure the mTurk sample was not contaminated by bots? Sounds like he's run into that problem in the past.
Yeah, I think I don't. The company mentioned a number of things that they have their internal kind of process to handle this. but we had some fairly strict measure of one, we had some attention checking items, 3 attention checking items, and if missed like even one, we actually toast that data actually, and at the time limit, whether it's like I think we actually piloted this quite extensively, and we learned that on average people completed the survey like 30 minutes, 25 to 30 minutes, and those people who finished before like 10 minutes, we also like exclude these people, and then long time, like I don't know, more than an hour or something. I think the chance of these data contaminated by bots, I think it's fairly low, but of course these technologies are also developing, so who knows? We might have to have a better system to check those kind of issues in the future.
So we also have another question. I don't know if you can see the chat box. I'll go ahead.
Yeah, so I will go one step above from the pain scale has limited range, say 0 to 10, and their mean over time would not show much change. Considering the subject started mostly on high scores, maybe a sort of quantile regression reveals better and more interesting patterns and information. Yeah, this is actually interesting and really valuable suggestion. Yes, the pain scale does have, like, it is definitely 0 to 10 numerical rating scales. And yeah, you can only just see the how much it changed from 0 to 10, but not really kind of represent percentage of change. So this is actually really suggestion. We submitted this paper now, so it's under review. But I think this could be an interest. Maybe I think reviewer would actually ask this. But regardless, I think we can provide this as a supplement material. Thank you.
Dr. Noor Baluchi is a statistician, so another fine service of Pain Research Working Group. A little bit of stats
Yeah.
tips or suggestions for those of us who attend. I did want to just mention a little bit when you turn your head, your voice breaks up a little bit.
I'm sorry.
I want to make sure that's okay. I know it's hard sometimes with all the technology we have to deal with. So I'm going to see if anyone else has any other additional questions.
Moon, I had a question about when you're looking at the baseline data, there was, it looked like there was a lot of mental health pain treatment, which I'm assuming is kind of like CBT or mindfulness or some sort of behavioral type treatment, self-management treatment, was moved to telehealth. And then a lot of the more physical treatments, physical therapy, some integrative pain medicine, those were largely canceled without follow-up. And I wonder if this is kind of a commentary on treatment in some regard, because we saw sort of there's a decrease in some of those treatments, maybe a bright spot for CBT in that it was moved to telehealth and we didn't see dramatic drops in pain, or at least perceived dramatic drops in pain. People didn't say, my pain got worse or my pain got a lot better. So I wonder if this is kind of a commentary on pain treatment as well, and that telehealth was A, maybe effective at providing treatment, and B, maybe some of these other modalities weren't helping pain as much as we thought they were, or I don't know if we can connect those dots or not. But I mean, it's so dramatic how much of those were canceled, yet we didn't see this spike in pain that we would expect with treatment. Ceasing.
I agree, and I feel like maybe VA might be the perfect setting to explore those kind of actually findings, because you know, I believe that you know, the VA might have all the electronic health record data before and after pandemic, and I'm pretty sure a lot of those mental health treatment providers quickly transitioned to all the telemedicine option. And it would be really interesting to actually look at this data before and after that was implemented, and whether there was like substantial increase or decrease or change in pain and functioning or mental health issues.
I mean, to a certain extent, it does make me feel better as someone who's kind of thrust into telehealth, having zero training in it, as maybe many people in this call didn't have training in it as well. That we could have been effective, and then, you know, being able to provide treatment using a completely different modality and still have it be effective at kind of at least staving off significant increases in some of the variables that we were trying to treat, like pain severity.
Yeah.
I think it maybe is a good prognosis.
Of course, this is a sample size of like 1 or 2, but my colleagues who are working at the rehab center was saying that a lot of her patients were reporting how actually they're grateful with working at home, and they can actually pace themselves better. And there are more like opportunities to actually go to sessions and also practice those kind of skills. Because, you know, certainly you don't have to like commute and park and also, you know, travel for, you know, appointments. And I think these are all like, I think the positive effects. We just, like, I guess we were not, I think the data will tell us more clearly about this impact, but definitely, I think it's great that at least the mental health providers were able to quickly transition into this line of service. I'm not really sure though, like some other like alternative complementary treatments, like how they're actually doing. And I'm pretty sure there are a lot of people like probably returned after getting vaccinated, but I'm still aware that there are a lot of people who are not comfortable going into really this like close physical contact, especially something like acupuncture or massage. I think there are a lot of people who might be uncomfortable moving forward with that. Yeah,
That's a really interesting question. Oh, go ahead. I think you're probably looking at the chat now.
yes, so we just like gave some examples, and like it's what exactly Dr. McLean mentioned. We put like cognitive behavioral therapy, mindfulness, meditation, yoga, exercise, and Tai Chi or some other stuff as a self-management treatment for pain. And so we don't exactly know which one that they were referring to, but they were saying that they increase in using these.
So I can see in the chat, so you mentioned VA and kind of the benefit of the VA electronic health record. And so Dr. Goldsmith mentions that they actually have a VA cohort in which they're actually able to investigate some of these questions. Dr. Norbalucci is on that team. And I didn't know, not to put any of you on the spot from the Minneapolis team, but is this something that you're currently looking at? It sounds like it. Is there anything you'd like to add on that note from your current work?
Hey, this is Lizzie. Can you all hear me?
Yeah.
Hey, thanks, Dr. Moon, and thanks, Dr. Heapy. Yeah, we don't have any results. We are just starting. It's Dr. Aaron Krebs' EPOC study, which is probably a cohort that you're familiar with, that monitors folks who are on long-term opioid therapy for chronic pain starting in 2016 in the VA. And we have a subset who engage in yearly surveys that include self-report pain measures, the same ones that you mentioned, as well as use of other non-drug therapies for chronic pain. And we have a supplemental funding that just began to look at ways in which people's self-reported experience with different COVID pandemic factors may have affected their pain, and then also their use of therapies, and looking at sociodemographic factors as well. So we haven't begun, but it's in process this year, and so would love to stay in touch. Really appreciate you sharing your work.
Sounds really wonderful. Well, we've definitely like more insightful than this study that was just based on mTOR sample. But yeah, I wanted to mention that we submitted this manuscript to Pain, but just got desk reject. I thought that was interesting. So it's under review in general pain, but I don't know. Maybe the editors didn't believe that when we said that actually all of like pain related outcomes didn't really significantly exacerbate it. It's not true. So who knows? But we wanted to be transparent and wanted to report, and I'm sure that there will be studies that could be like contradicting to our results depending on the sample and where like how it's collected.
I mean, there are people with a lot of experience on the call who might be able to weigh in on this, but I hear that Dr. Norbelucci's point that, you know, there may be variations in the scores that quantile regression could elucidate more, and you might be able to find, you know, different subgroups that are of interest taking those different approaches. I don't know if others on the call who have not looked at BPI for decades have suggestions there.
Any other questions, comments? And I'm more than happy to share these slides with you. This call.
Great. Thank you so much for that. Often folks will reach out to us. You can reach out to Ross or I, or Jung himself, I'm sure. And we're happy to pass on PDF of his presentation from today if you're interested. I do appreciate the point. You know, this is a huge occurrence that none of us planned for, and there are many, many different ways to come at the information, right? Many ways to look at it, all of which add to our knowledge. So that was really very helpful to be thinking about it and discussing it today, and we thank you for joining us. Thank you everyone for attending. I hope you have a great October and start to your fall, and talk to you again next month. Thank you. Bye.
All righty. Bye, everyone.
Okay.
Thank you, Ross, and thank you, Alicia.
Take care.
Bye.
Yeah.